Recording, please. A very warm welcome to everyone to today's virtual event that is titled The Value of Patient Navigation for Oncologists. My name is Jessica Kilonzo. I am based in Nairobi, Kenya. I lead the team that facilitates the Global Virtual Community of Practice for the American Cancer Society Beacon Initiative. Through our Beacon virtual event, though our Beacon virtual events are normally presented in a closed format to our current community members, we are excited today to open the doors to the general public for this event, given the importance of creating broad buy-in for patient navigation, and especially in low and middle income countries settings where patient navigation is a continuously emerging practice. We are delighted to see the many new faces online and hope that you will enjoy today's program. Next slide, please. So this is how our event is structured today. The session is designed to spark engaging conversations and offer diverse insights. We will kick off with a brief presentation that sets the stage for our discussion. After the presentation, you will have the opportunity to meet our hosts and incredible panelists. We will dive into a discussion where our panelists with varied oncology backgrounds, representing different countries and regions of the world, will share their personal insights on how supporting patient navigation design and implementation and collaborating directly with patient navigators can improve care experience for both patients as well as the healthcare teams that serve the patients. After our host asks some prepared questions, we will open the discussion for all of you present today in our question and answer session. We encourage you to participate actively in the Q&A session by sharing your questions and comments. Remember, you can begin to put your comments and questions in advance as the conversation is ongoing. Please keep your questions strictly focused to today's topic. We will then conclude with a brief announcement. Kindly note that we have planned to have this for about an hour. However, if the discussion continues to flow, we may stay on for a few extra minutes. Feel free to stay on as long as you can. I would now like to introduce our hosts for today's discussion. Christy McComb, the Managing Director of the Global Capacity Development and Patient Support Team at the American Cancer Society. Christy oversees the SCS Building Expertise, Advocacy, and Capacity for Oncology Navigation that I have previously referred to as Beacon Initiative. This is a global capacity development initiative that supports health institutions and cancer organizations in low and middle income countries and other relevant settings around the world that are focused on addressing health disparities in cancer care, in designing, implementing, and sustaining cancer patient navigation programs. The Beacon Initiative equally supports the integration of patient navigation in cancer control, planning, and cancer care delivery. Christy, the floor is yours. Welcome.
Thank you, Jessica. I want to echo Jessica's welcome to all of you today. We are so thrilled to have a diverse audience of participants with us, oncologists and healthcare professionals from around the world, our esteemed panelists, which I'm so excited to introduce you to today, our sponsors and supporters, in particular, the MSD Foundation, EMD Serono Incorporated, and our Fantasy Fair community of volunteers. Also our ACS leaders and colleagues, and of course, the dedicated and hardworking members of our Beacon community who are systematically bringing the reality of patient navigation to new corners of the world every day and defining what oncology navigation looks like outside of the United States context. Our goal today is to explore how patient navigation, in addition to improving the cancer care experience for patients, can benefit oncologists and other healthcare professionals who are crucial stakeholders for any patient navigation endeavor. We plan to clarify the unique role of patient navigators and help you assess the potential impact of integrating navigation services into your own practice or your work setting. Throughout this session, we will touch upon topics such as stakeholder buy-in and partnership development, and we'll address common challenges that emerge particularly from oncologists and healthcare professionals' perspective when patient navigation is introduced for the first time in a new setting. And the result that we seek today is that you all leave this call inspired by our guests and motivated to implement patient navigation in your setting or support others to bring it to fruition for the benefit of individuals and cancer patients everywhere. Next slide, please. So to frame the discussion with our panelists today, I'd like to ensure that we all have a basic understanding of some key concepts. And if you already know these, please bear with me. To understand the potential and power of patient navigation, we first need to understand barriers to care. A barrier to care is any factor that delays or prevents an individual from accessing appropriate and needed healthcare in a timely fashion. There are many different types of barriers, as we show here on the slide, and they contribute to socioeconomic, racial and ethnic, and geographic differences in healthcare use as well as health status. And additionally, barriers to care often stack on top of one another and most affect those who are already disadvantaged. In the context of cancer care, which is often a highly complex and both time-sensitive and time-intensive experience for an individual, the barriers to care that a person faces can be the reason that they never get screened for cancer in the first place, that their cancer is diagnosed too late, or they delay or don't complete treatment even if they manage to start it. So what is patient navigation? In the cancer care setting, patient navigation is defined as individualized assistance offered to patients, families, and caregivers to help overcome healthcare system barriers and facilitate timely access to quality health and psychosocial care from pre-diagnosis all the way through all phases of the cancer experience. And though patient navigation has historically and still continues to be predominantly implemented during the diagnostic and treatment phase, which is the focus of what we'll be talking about today, we know that it has applicability across the continuum, and we encourage its utilization in all phases, from prevention through end-of-life care. Next slide, please. So, how does patient navigation achieve these goals? Well, given the myriad types of barriers that individuals and patients face, barriers that occur at home, in communities, on the way to seeking services, and even as people are receiving services, there are different types of navigation that can address these challenges. In the Beacon Initiative, we talk about three main types of patient navigation that align to these different types of barriers. What we know is that these types of navigation work together to meet those full range of patients' needs, from the home through the community all the way through the health system. The more of these types of navigation that are working together, the greater the chance patients will have to complete their cancer care journey as planned. So, starting with clinical navigation, this really helps patients to overcome health literacy, communication, and psychosocial barriers. And this typically takes place during the diagnostic and treatment phase in a health facility setting. Resource or non-clinical navigation looks at those logistical, financial, and other resource barriers. Think again of the patient who needs to organize childcare, perhaps transportation and accommodation. This is particularly acute in some of the countries where you're coming from, where cancer care is concentrated in one large city far away from the patient and all those needs that they have to seek treatment. And finally, physical navigation addresses mobility and language and literacy barriers within a facility. So again, imagining patients who are traveling very far to a new city, may not speak the language, may be very sick by the time they arrive, getting that needed support in that treatment phase. Patient navigation, so how is patient navigation done? Well, it is carried out by individuals or teams of individuals known as patient navigators, and they perform vital tasks such as seeking solutions for individual level patient problems, anticipating patients' barriers, identifying resources, and making plans of action. They help to increase patients' awareness of and access to those resources. They facilitate that provider and patient communication. They enhance informed decision-making by patients and ultimately empower patients to self-manage their care. But to be effective, patient navigators of any type and function must create and maintain relationships with various individuals and entities, both within and outside of the healthcare facility. Thus, it is crucial to create buy-in for patient navigation from the outset. But gaining the support can be challenging, especially in clinical settings where other aspects of the delivery system are not yet optimized and are quite challenged, and also where many healthcare professionals, especially oncologists, are often stretched thin and overwhelmed trying to manage large volumes of high-need patients. But as they say, where there is a will, there is a way. And today we are honored to feature oncologists from the United States and several low and middle income countries who will share their personal experiences and perspectives collaborating with patient navigators and their insights on the value and benefits of patient navigation. So next slide, please. I'm now pleased to introduce this wonderful panel of oncologists from 4 regions, all with unique perspectives and varied experiences with patient navigation. There are too many professional accolades and accomplishments of these individuals. I'm going to share a few in our short time together, so please excuse my brevity, but just know this is a great group. First of all, I'd like to introduce Dr. Anurag Agrawal. He is an American pediatric hematologist, oncologist, and bone marrow transplant physician. He recently joined the American Cancer Society to lead the Global Cancer Support Department. He brings the unique perspective of delivering cancer care in a variety of resource settings and has a long history of global health work. Most recently, he was involved with the development of the Southeast Asian Pediatric Hematology Oncology Project in 2016 to improve pediatric cancer outcomes in Vietnam, including initiating a 2-year master's level training program that is ongoing today. He has also served as the medical director of pediatric hematology and oncology in Gaborone, Botswana, and as a pediatric AIDS core physician in Lesotho. In his new role at ACS, today is his 101st day with us. He is leading the charge to build a global patient navigation alliance. So please watch this space and please get involved. Next, I would like to introduce Dr. Eduardo Casap, who is an Argentinian medical oncologist and the founder and first president of the Latin American Caribbean Society of Medical Oncology, known as SLACOM. He is also the past president of the International Union of Cancer Control and emeritus professor of the Latin American School of Oncology. He is a promoter of the concept of global cancer control and advises and collaborates with leading international organizations such as the WHO, UICC, Aortic, ESMO, and ASCO, among many, many others. He brings the wisdom derived from a long, illustrious career, supporting many countries across his region in their efforts to improve the cancer experience for patients. Next, I'd like to introduce Dr. Uchechukwu Nyeka Shagaya, who has given me permission to call her Dr. Shagaya. She is a Nigerian senior consultant, clinical and radiation oncologist, and the former head of the Department of Oncology and Radiotherapy at the National Hospital Abuja in Nigeria. She is currently the head of training at her Center for Resident Doctors. She has a strong interest in community oncology and is a steadfast champion for improving cancer care in Nigeria based on her leadership and contributions to date in a variety of cutting-edge efforts such as oncology telemedicine, development of a government health fund for cancer patients, and expansion of a multidisciplinary team approach to oncology throughout the country. She is an admired mentor by many, and most importantly for today's conversation, she is an enthusiastic advocate, early adopter, and leader for patient navigation implementation and expansion in Nigeria. And our final panelist, but certainly not least, is Dr. Angela Gizelvania, who's also given me permission to call her Dr. Gizel. She's an Indonesian radiation oncologist and head of the Radiation Oncology Services Unit at Dr. Cipto Mangunkusumo Hospital in Jakarta, Indonesia. She is also a lecturer in the Faculty of Medicine at Universitas Indonesia and the president-elect of the Indonesian Radiation Oncology Society. She leads her hospital's collaboration with the Indonesian Cancer Information and Support Center Association, known as CISC. This is a voluntary patient support organization and one of our most active participants in the Beacon Initiative that provides non-clinical navigation services within the hospital. Like Dr. Shigaya, Dr. Giselle has been a consistent and proactive champion for patient navigation since the beginning of the program, and she is actively contributing to broader planning for patient navigation expansion in Indonesia. So welcome everyone. So excited to have you here. I know you're coming in from different time zones, so thank you very much. Let's go ahead and get started. We can minimize our presentation and focus on, yes, thank you, our panelists. So my first question to all of you is, could you briefly introduce yourselves and tell us about the settings where you work or have worked as an oncologist, the clinical setting or the patient population you've worked with, and how and when you first became familiar with patient navigation? And maybe we'll start in the order that I presented you in the introduction. So Dr. Agarwal.
Great. Thank you, Christy. Thanks for having me on the panel. Really great to see everybody. So as Christy said, I've had the benefit of working in multiple different settings as an oncologist. So in the United States, as well as in Africa and Habaroni, also briefly in Ethiopia, and then most recently in Vietnam. So I've been able to see oncology in many different settings. And also, I think the way I think about navigation is thinking about settings where navigation exists and also where navigation does not exist. So in the United States, as mentioned, we've made a lot of progress with navigation, but still have a long way to go. The complexity of therapy has only increased. And so we see many patients who benefit from navigation, especially if they are accessing clinical trials or having to go to other settings and really understand a really complex disease process. But as I said, comparing that into situations where there isn't navigation to really help them through that process. And same in many of the settings where I've worked in the low and middle income country settings, again, as Christy mentioned, seeing all of the challenges that the families have in accessing therapy consistently and being able to complete therapy. One highlight is a program that we work with in central Vietnam. It's a city called Hue, and they've had a very, very strong social support navigation program for many years. And they're really a foundational landmark program in Vietnam. They have zero abandonment, which is, it's not an exaggeration. It's very amazing program that they provide, really holistic, patient-centered, family-centered approach, and really are able to provide all of the support necessary. So, and then I see that as compared to other centers in Vietnam who don't have those services. So I think that comparison is really quite stark, and that's what we've seen so far in our work, and really excited to continue that growth of the programs. Thank you, Christy.
Dr. Kaza, you come off mute.
Yes, hello everybody, and thank you very much, ACS, for your kind invitation. Well, I should share with you that the picture in the Latin American region is complex. It's complex for cancer care and control, and of course, to other diseases. And why? Because from Mexico to the south, the issue is that cancer care is highly variable and depends on the structure of the country. We have, as an example, small countries like some countries in Central America or Uruguay, that they have an unified healthcare system that covers, in general, a great proportion of the population. So that is a picture that has advantages for the implementation of improvement tools for better cancer care, as navigation is. On the contrary, you have large countries, Mexico, Brazil, Argentina, Peru, in which healthcare systems are very different, and you have fragmentation and no coordination of healthcare systems. As an example of this, Argentina has 7 different levels of healthcare systems: national, provincial, private, the unions, the militaries, and it is sad to say this, but the cancer care is provided, but fragmented, non-coordinated, and of course, patients and doctors are dealing daily with many, many barriers that really are blocking for the success and the efficiency of the systems. So if we analyze the problem specifically for navigation, I should say that first, the majority of us have no idea about the different navigation strategies in most of the countries. If they exist, or they exist in paper, something that is very common in our region, but never were implemented, or they were implemented during a period and then due to multiple reasons, economic, administrative, governmental, the projects of navigation were cancelled. So our idea is that first we need to set a map of how navigation is integrated in the different health systems in our region. Why? Because this is fundamental in order to have an idea, and I am very sorry to share this with you. Our information is very poor. The second thing that I consider is that we need perhaps to coordinate navigation with national cancer plans. Because in most of our countries, national cancer plans are the governmental guide for cancer care and control. And then I think that a coordinated effort from different sectors and countries will need to discuss the issue with some data to develop a country and regional strategy. And I think that one of the first and urgent measures should be information for patients and doctors about navigation, because the knowledge about navigation in many settings is very poor. Thank you.
Thank you, Dr. Kazap. And I feel like you are promoting the Beacon Initiative, perhaps.
Maybe.
Maybe. Okay, I'd like to ask Dr. Shagai. Let's go ahead and get into the conversation. I have Dr. Shagai and Dr. Giselle, who are current practicing oncologists, quite new to navigation. Dr. Shagai, I want you to share your story of your first encounter with navigation and how that motivated you as an oncologist to bring it to Nigeria, or at least to your hospital setting.
Okay. Good morning, and thank you for having me here. So I was in Kenya for an IAEA meeting. Had nothing to do with navigation, and part of the excursion, they wanted to take us to the Kenyatta Hospital and just to see around the place. And we walked into the clinic and I saw patients everywhere. You know, they were sitting in the shade, sitting in the lines, they were everywhere. But something that struck me was they were very calm. They didn't seem to be, they just were, you know, sitting, you know, nice. I just, you know, I put it behind my head and I continued going through the corridors asking about number of patients they see, number of machines they have, what time they start work, the shifts, you know. And then in my head, I said, oh, maybe they have, you know, 4 or 5 machines, that's why. And they said, no, we have 1 machine. I'm like, well, 1 machine? How many patients are you guys treating a day? And they're like, oh, about over 90. How many shifts do you have? Oh, we have 3 shifts. Then I came back out and I looked at the patients again, still calm. In my head, I said, you know what? East Africans are probably calm people. In West Africa, the heat makes us extremely aggressive. Maybe that's the reason. But it just kept on needling me because at that time I was seeing a quarter, no, maybe half of what they were seeing. But you walk into my clinic, the patients are at the necks of the medical records, the nurses, there's so much chaos going on. And you know, actually we're headed towards the bus, and I said, no, hold on, I need to ask some questions. So I ran back in and I asked, and I said, look, what is the magic? I know, yes, East Africans are, but come on. How are you able to control 100 people coming in here every day? And this is not 100 people who are comfortable, 100 people who are ill, anxious, waiting for treatment. How are you able to control this? And they said, oh, we have a patient navigation. In my head, I'm thinking like customer service, so like, how does that work? And they're like, oh, no, come, so they took me now into the rooms through the process, showed me the forms, explained everything to me. And it was like, "Ooh, this is amazing. Could I do the same thing back home?" This was just a thought. I mean, remember, I'm just hearing about this for the first time. So I get back home and I send an email and I'm told, oh, they have already finished, but you really sound excited. Read a bit about it. And if you're interested, we will talk to you. I spent the next 2 days, I was sending emails, I was reading about, I went to every patient navigation site I could find online and I was reading about it. And a few months down the line, we started in December of last year. We joined the Beacon. And the amazing thing about the Beacon initiative is that it literally takes you from no idea what patient navigation is to becoming not just an advocate, but to someone who can actually teach it. So, because I've just mentioned about the cancer control plan, for us in the NMIC, it's extremely important. So I've been able to talk to our Federal Ministry of Health. They've seen what we're doing. They like it. If you come into my clinic now, it looks like a VIP clinic. The patients actually feel cared for. That antagonism, that aggression, it's no more there. They feel heard. They come to the clinic. I've put it, how where you'd have your greeter's office is right at the entrance. Beautifully colored, nicely, very serene, little tiny cubicle. They go in there, they feel very private. They get personal phone calls. They're given a glass of water. They talk to them. So by the time they come out and they're taking their vital signs and they're seeing the doctors, they feel heard. So for me, I am a pro, patient navigator because I've seen the before, I've seen the intervention, I've seen the after.
And you don't want it to end.
Oh, no, I don't want it to end. Not
Yeah.
at all. Not at all.
Thank you. I love your story. I love hearing it, and so glad you're part of our community. So Dr. Giselle, again, talk to us about the first time you heard about navigation and the setting that you're working in Jakarta.
Thank you, Christy. So I'm working in the radiation oncology department in Jakarta, Indonesia. We see around like 1,700 patients per year. And for our patient navigation program, we are partnering with the Cancer Information and Support Center, CISC, led by Ibu Arianti Baramle. I believe that she's here also today. And our patient navigation program is among the first in Indonesia. So at that time, in 2022, we haven't got any previous model of this kind of patient navigation before. The Prof. Suhartati Gondowiarjo is among one of the first who introduced the concept of patient navigation in our country. And then with our close partnership with the CISC and under guidance and support from the ACS Beacon, we launched this program in September 2022 and have been working hand in hand since then with the CISC. Thank you.
Thanks. So I know it's easy for us to already think about that implementation at a bigger scale, but implementation also starts hospital by hospital and healthcare team by healthcare team. So maybe just opening it up as an oncologist, what you've talked a bit about the benefits that you're seeing, but tell us about the challenges that you faced in introducing it, or in the case of Dr. Agarwal and Dr. Kazap, in that day-to-day service to patients, have you run into challenges integrating navigation into your care delivery? And anyone can take this.
Okay, let me say. So I got back to Nigeria with a lot of ideas in my head. So The first thing I did was to go through the Beacon platform. I went through the toolkit, so I knew what I wanted to do. But how was I going to get management to understand how this was different? I tried to have a couple of meetings and it was always brushed off. It just wasn't taken seriously. They just didn't seem to get what I was talking about. So I knew there were a no-go area. So I said, okay. So I did the maths, economics of how much it will cost me to do 1 year. And I brought out a pilot and I decided to launch it side by side. Because in Nigeria, we have things like World Cancer Day, Breast Cancer Month. We have times when everybody just suddenly remembers there's a cancer. And then by next week, they've forgotten. So I timed it with one of those. And I had I had something on patient information. The patient matters. That was what I named it. And then I had my patient navigation put together. And I called management and just said, I want you guys to come and, support me in this. They had no idea this same patient navigation I'd been talking to, because I'd mentioned it before the Beacon, before I met the Beacon. But at that time, to be honest with you, I really didn't understand it in depth. So when they arrived and they saw the cubicle, they saw my navigators, they were a bit shocked. It was like, and I said, oh, no, it's all in for the patients. It's all about the patient's matter. Like, oh, okay. But the minute one or two of them had patients who had to go through the system, that was when I really brought them over. It's about when you take it upstairs to them, honestly, they don't want to talk about the extra cost, the extra personnel, the extra, it's just like, oh gosh, there she comes again. But if you're able to do all this without their input and all they have to do is come and take the glory for it, then they'll be fine. So that's what I did. I did all the groundwork. I did everything. I just asked them, come and grace the occasion. And when, questions were asked, I gave the impression that it was management who was doing it. It was their idea. Then they were fine. As long as you're not asking for money or time or more people. And then another thing I did was to make sure I had navigators who were employed and trained specifically for those positions. I didn't take staff from the hospital and convert them. No. I had brand new people coming from, yes.
Thank you. Someone else like to chime in on that?
I can just add that yeah, I 100% agree with everything that was said, and congratulations on your work. And I think that it often takes a champion to get things started. And I think that once people see the value, then you can start to move things forward. I think that is one of the challenges sometimes, is to find that champion. But those are universal problems. We face the same pushback even now in the United States, as far as the resources and the management not understanding the need. But once you walk with the patient and the family through the journey, and you understand how difficult it is, it becomes much easier to see the value. So our hope is that as more and more people hear these stories and the value, that will start to move the snowball down the mountain a little bit faster.
Would somebody else like to speak?
Yes. I think that the experience of Dr. Sagawa is fantastic, and it is a clear example of a down to top strategy. But we think that in order to have a wider possibility of application, is trying that's something that in our region, Latin America, is most likely to use a top-down strategy. And why? Because it is important to put in the minds of policymakers, people from the government, that in the healthcare systems, the center is the patient. But that is not true. the majority of the healthcare systems that are in place in most of our countries, the center of everything are the doctors or the administrators or other people, ministers of health, that have no idea about how the health systems must be organized and efficiently managed. They think that building hospitals is the issue of their role as part of the government. And that is not true, because in Latin America, for example, in my country, the people is spending 10% of the GDP of the country in health. This is not the case of countries without economic resources, but the resources are very poorly allocated, fragmented, or not distributed in the way that is necessary, efficient, and really taking in consideration, as Dr. Chagayas said, patients waiting. Doctors should wait, or the people or the minister should wait, but not the patients. But when you enter to most of our hospitals that are from the provinces or the states or the governments, the lines are a daily thing.
Yeah.
So I think that this is a philosophical question in
Right.
which education and information, not only about patients, we need to educate policymakers, we need to educate people that are related with the health system, because if not, we need to rely in individual efforts that are much more difficult, because it's one person fighting against the system. We need the system working at the side of the people, patients, doctors, and the public in general, or healthy people, because the idea that health is for patients is wrong. Health is for everybody, because if we do not include prevention of healthy people in the healthcare system, something is wrong.
And that's a really good point. I mean, listening to all the different scenarios, healthcare systems, and all of those, if they don't have that patient-centered care approach or people-centered care, and that's a lot, we frame navigation in the Beacon Initiative as the embodiment of people and patient-centered care. So absolutely, we have to address those. I'd like to ask Dr. Giselle, again, as an oncologist, new to navigation, what has been your experience? How have navigators helped you do your job better? And what kind of tensions or challenges have you seen as the program has gotten off the ground? And you are on mute.
Okay, thank you, Christy. So in our experience, I think we oncologists and healthcare staff are usually not having a lot of time, enough time to support the psychosocial or economic aspects for the patients. But we do understand that when a patient diagnosed with a cancer, the whole family will suffer, not just emotionally, but physically, economically, and everything. So while we are the doctors only taking care of the medical aspects of the patients are still need cares for the non-medical aspects. I think that's where the patient navigators can help us as the oncologists. The data from our study in our hospital done by our resident Kabisat, the radiation interruption in our department in year 2022 showed that non-medical aspect accounted more than the medical aspect. So it's like 42% compared to 32%. The other is the COVID that time. So looking at the data, that the major reason of the interruption was due to the non-medical aspects, such as no transportation, nobody can accompany the patients to the hospital, or self-decision of the patients to postpone because there may be lack of education and everything. So with the patient navigation program, this kind of barriers can be reduced with the right assistance. That is why data from our study done by also our resident Dr. Susanti showed a decreased trend in radiotherapy interruption treatment after the program applied in our department. It is reduced by like 3.43%, but it is account like for more than 60 patients. So
That's
it's
huge.
quite good.
And the program is less than 2 years old.
Yes.
So only more good things to happen. Would anybody else from that oncology kind of mindset or your personal perspective as an oncologist, what have you seen directly as the benefits? Has it made your job easier? And or has it made it more difficult? I'm curious because you know, when we think about change and introducing, I know Dr. Shagai, you talked about the healthcare administrators buying into this, but how do we get oncologists and healthcare providers to buy into this integration of navigation and navigators into the system? So there's a few questions in there. Feel free to take one.
Okay, so when we started, I had the 8 oncologists in my unit. I had only one on my side. The rest felt it was a waste of time. Now, let me give you a bit of background. We have an inherent distrust for non-governmental organizations in my country, but that's because of,
Non-governmental,
yes, we
community
it's,
organizations.
yes, it's something we're very, you know, because we've had very bad experiences with them in the past, you know. So of the 6, I had only one, so it was just 2 of us who were part of it. And it was a bit tough. The first 2-3 weeks were a bit, you know, tough because if your consultant is not keen on something, the likelihood the patient is going to be part of it is slim. And when they introduce you to it, there's a part there where they tell you it is optional. And in Nigeria, when you say optional, what the patient hears is, I don't have to do this.
As opposed to, this is this great service if you want it.
Yes, it's free. I'm not paying. It's optional. There must be a catch. They don't trust it by default. So we went on like that for about 2 weeks. And then the patients who were navigated were the ones who used to kind of like brag to the other patients.
Interesting.
Who were the ones who were having it easy. So those who were not being navigated now started feeling left out. Like, how come? Oh, I got called yesterday. Yes, I was reminded I have my test ready. Blah blah blah. You know, that was actually what helped to push it. The patients were the ones who helped to push the navigation in my center. By the time other consultants started coming on board, we had already gone through some really major barriers. Because what now happened a few months later, a few consultants traveled and saw the navigation and like, wow, is this what Dr. Shakir was talking about? Oh, and we didn't give her the support we should have. Oh my goodness, this is so great, blah, blah, blah. So they came back with, you know, guns blazing, you know, and the navigators are like, we've been doing this, we've been here. So now we have a very unified, everybody has come on board.
So the
But
patients have been the real champions as well.
But it was the patients who I think who pushed, because you know the patients talk.
Mm-hmm.
You know, patients talk.
We've heard that in Kenya too, where you saw the program. They've been some of the ones going home and talking about this much better experience they were having at the
patients
hospital.
talk. They tell you how, oh, I got my medical referral in 24 hours because Navigator helped me get it. I got onto the Cancer Health Fund quicker. I got this. Oh, so those who don't have that start asking themselves questions like, maybe I should have gotten navigated. So when we started, we said we're going to start on like day 1 and every new patient from then. But we found ourselves having patients who had been seen before the day we launched, who insisted that they wanted to be navigated. So but I said to them, you know what, don't discriminate. Just take them at whatever point you can and try to figure them out. Because it was easy to start from the first day, you know, first day you walk in. But when you have patients who have been patients for 3 months who say, oh, I want to be navigated, you know, it was a bit difficult, but I just said, you know what, it's all about the patient. Pull them in, figure out what you can do, and then let's just, you know. So it was, for me, it was the patients first, then my colleagues.
So I'm going to pause here. I'm looking at the time and check in to see, Jessica, do we have any questions in the chat? And if we don't, perhaps we do give a minute to open to the floor and see if we have questions or comments from our broader community. Jessica?
Great contributions from the panelists. We do have comments that are coming up, not specific questions. So, and we appreciate, I will not read all the comments. I would probably say, Christy, maybe we can take another 2-3 minutes to hear from the panelists until we get questions coming through.
Well, you
I
know, one
wanted to
question.
add,
Oh, yeah,
sorry,
go
one thing.
ahead.
Yeah, I just wanted to add to all that what was said before. So I think hearing the discussion and also just with the work that's been done by us and stakeholders on the ground and many other collaborating partners across the world, I think that the needs of the patients are universal. I think the settings may be different and the complexity of the therapies are universal and the needs within each group are universal. And I think we're at a point now with so many groups and moving forward and seeing the value that we're really hopeful that we will start to escalate. And per Dr. Kazap's point, there has to be also a groundswell at the administrative Ministry of Health level to really move things forward. Because I think one of the challenges that we face is how do you maintain sustainable programs if they're championed by one or two people? If those people leave, then what happens to the program? So I think those two things have to happen in parallel. And I think we're at a point now where those two things are starting to happen in parallel slowly through the development of national cancer control plans, thinking about how navigation becomes fundable. And to that effect, we are starting a global alliance for cancer patient navigation, which will be sponsored by ACS. Our goal is, as Dr. Kazap also mentioned, first to really understand globally what people are doing and where, and who are they being supported by, and how do we work together to really elevate this issue at the global stage so that we really force country leadership to start to implement. And this is a problem in high, middle, low, middle. All of the settings have this issue. So I think it's a really great opportunity for us to together collaboratively build the momentum for this.
Yes, I agree with Dr. Agrawal, and there is also a very adequate comment here that problems are universal, but solution must be local because health systems are local. And I insist, I think that navigation has collateral benefits because the lack of information, doctors have no time to really give the proper information for patients. And traditionally, in many settings, nurses did that job. I think that navigation has an additional benefit that is patients are better informed, patients know more about their situation and the systems to really make the journey more viable.
Thank you.
Okay. Christy, we do have a question from Metal. And they're asking, for selecting navigators to be trained, did you work with survivors, family members, or did you work with social workers? I think any of the panelists can respond to this.
And maybe we can have Dr. Giselle talk about the model at your hospital, which does involve survivors, and then we can hear from others.
Thank you, Christy. So in our hospital, we work with CISC, which is independent cancer survivor group. It's one of the biggest in Indonesia. It has more than 3,000 members and some branches in provinces. So we work with them. We use the ACS module, the 16 modules from American Cancer Society Beacon. And then we add, because our hospital is also accredited with JCI, so we need to make our patient navigators can do the basic life supports and know about all the emergency codes in the hospital and also the fire drill and everything. So we equip them like what we can do for basics. And then also we add some knowledge like the approach for cancer treatment, such as the surgery, radiation oncology, medical, systemic treatment. So things like that. Also knowledge about the nutrition support in patients and rehabilitations, back to work, palliative, things like that. So that we make the whole module for them, ACS plus the local module. Thank you.
And Dr. Shagai, you're on mute. I think you're talking.
Mine was a bit different. So in my center, we actually train oncology nurses. So we're a training center for oncology nurses. So what I did was I had 2 physical navigators and then 1 clinical navigator. The clinical navigator is actually an oncology nurse, trained oncology nurse, but she's not there 9 to 5. She's around, she's like a circulating, she actually works in the brachytherapy unit, but we don't have brachytherapy sessions all the time. We have them on 2 days a week. So the rest of the days she's free to be with us. Now the physical navigators, I used the Beacon training kit and we trained them, went through all the lectures and all that. They are the ones who see the patients, who go through the first encounter, second encounter, do the distress assessment and determine when they think that, they need to send it to the clinical navigator. And then she's the one who will decide and say, look, I think this needs a psych consult. But I know from what I've heard from what Giselle has said, she has a very well-rounded navigator. For my navigators, so I remember looking, and it was secondary school was high school certification was the minimum. Jobs are hard where I work, so I actually have people who are university graduates. So I have one of them as a data analyst, and then the other one read biochemistry. Coincidentally, her mother was our patient. But I did very vigorous interviewing. I interviewed maybe like 10 of them, where I was just trying to find out who I thought would be a right fit. Another thing that I put in was the language they speak. I wanted them to speak English and one of the major languages, so they could double as translators as well. Yeah.
Yeah.
So,
And I think, yeah, and just hearing that again speaks to all the points we've made, the variability of the setting, your ability to hire and onboard, historical relationships with, the NGO sector, if you're a government facility. We see differences through Beacon, but all of it gives us an opportunity to right size what works in your setting, ensuring, of course, that whomever we bring into this are appropriately trained and working at the highest level of their licensure in the case of clinical navigators. So I think we have one other question, Jessica, I saw, or comment.
Yes, we have a question from Grace about
Yes.
what strategies, given that oncologists are busy and very busy, what strategies they can use to incorporate patient navigation. Perhaps Dr. Anu, Dr. Kazak, would you like to take this up?
I think it takes a partnership approach. I think there has to be multiple levels of support. Everyone is very busy, right? So it's easy to say, as Dr. Shagaya explained, understandably, her colleagues weren't on board at the beginning, partly because they were probably too busy to really grasp the concept and spend the intellectual time to think about it and even try to grasp how are we going to develop the resources, et cetera. So I think there has to be a multi-pronged approach. There has to be the local groundswell of effort. There has to be collaborative partners, and then there has to be the governmental buy-in. All of those things have to happen in combination to create scalable and sustainable programs. And again, I think we're at the tipping point where we're starting to see this in more and more settings as countries develop infrastructure and really want to provide patient-centered holistic cancer care.
I think that from a global perspective, you must be realistic. Oncologists are really unable to take care of the increasing number of cancer patients all over the world. So one of the possible solutions, I am not speaking from local or regional situations, only with as an helicopter vision of the problem, I think that in the next decade, oncologists will need to focus only in treating patients, and screening and the follow-up survivorship should be in the hands of other components of the healthcare systems. So at that point, oncologists will have enough time specifically for the needs of very, very complicated treatments or questions, familiar problems in hospital treatment that are or at home. So I think that we need to reformulate the way in which the health systems are managing cancer care from the point of the different doctors participating in the whole continuum of cancer care.
Thank you. Yeah, you're talking about task shifting and really thinking about, again, what's the oncologists need to be focused on. And navigators could fit in on some of those roles that you described. But you're right, we have a growing cancer burden, and are we keeping up? And in some parts of the world, we haven't even caught up to the current challenge of cancer cases. So thank you for that. I'm mindful of time. We're going to go a couple minutes more. Jessica, do you have another question? I think I see a couple here. And you're on mute, or maybe I can just see, I see Nancy Pena, who's also a really active member of our community, who works as a navigator in Boston, but also supports navigation expansion in Latin America. She's kind of the dual two-hat person. She probably wears 5 hats. Anyway, she's asking, what's the best way to work with ministries of health to present the benefits of navigation and implement it in public hospitals? And I think maybe that could be, again, Dr. Shagaya, some of the work you're already doing in Nigeria, maybe Dr. Giselle as well, Indonesia. If you want to just say a couple words, what have you done, how have you advocated? Knowing that you can't advocate officially because you're a government employee. And you're on mute.
Okay, so on the advocacy level, I happened to be on the National Cancer Control Panel. So we're there, they're talking about cancer of the cervix by 2020. I think we're not able to meet that deadline. They have, every 5 years they have different deadlines. And then at some point they said, anything else? And I put up my hand and I said, look, there's something I'd like to introduce into, and it's called patient navigation. Coincidentally, I had another member there, Dr. Obo, who's also Okwo, sorry, who also is a Beacon member,
Yes.
but his center has not been as, productive as it ought to because of management, buy-in. So the representative of the Federal Ministry of Health was like, patient navigation. Like, what is this? I said, hold on, let me just explain. So I went through it in about 10, 15 minutes. And he was like, wow, okay. And I'm like, I don't see any reason why we can have this in every center. There are 44 centers across the country. Why can't we? It doesn't have to be a big thing. It could be one room. It's just the concept, the fact that you have that and you plan to have every patient's hand held, and and then he said, okay, fine. So one of the things I'm actually tasked with is to make sure my project is a success. If it works out perfectly, then I'm able to, they'll now let me be the one to guide them through. I might not be able to go in person, but I'll be able to do virtual things, have meetings with them, train them, and then lessons learned. Because I learned a lot from the people who had started before me, who couldn't, who got in trouble along the way.
Yeah.
So that's my own way of advocating. But if I wanted to go straight, because there's another parastatal we have, Nigerian Institute of Cancer Research and Training, NICRAT. It's a new one.
Yes.
They're going to be probably very influential. I've thought about talking to them about it, but I'm going to wait a bit to see if Federal Ministry of Health is not able to, then we'll go through the NICRAT. But I think Federal Ministry of Health is more encompassing. That's the least as a clinician you can really do. It doesn't much you can do with regards to policy. But if you sell the idea to them, they see a successful pilot, then they might want to do it. So that's what I'm doing now.
Thank you. Dr.
Sorry,
Giselle?
can I
Oh,
say, hello, can I say words from Friends of Health Abuja, Nigeria?
Oh, there he is. Uche, you're there?
Yes, I'm here.
yes.
Oh, perfect. So talk more about it then.
Yeah. Thank you, Saga, for all your presentations and the work you're doing in National Hospital Patient Navigation. Just to say that we keyed into patient navigation 3-4 years ago, even before the Roche grant came to Enugu National Hospital. However, we started with the pediatric oncology. That's where we piloted, and it's still ongoing right now in 4 hospitals, including National Hospital, of course, Gwagwalada, Calabar, Ife, and Enugu. So the Friends of Health has fully bought into patient navigation program. While we pilot in the 4 hospitals, we are hoping to expand to as many hospitals as possible because what Shagai is doing in National Hospital is quite interesting. And we are trying to harness the experience in National Hospital with the adult oncology, and then what we are doing in other hospitals with the pediatric oncology. So we're trying to use the 2 models to be able to expand to other parts of the country. So advocacy-wise, Shagai has done a great job, and with our team, and the highest political level in the ministry has bought into it, and we're hoping to expand to that going forward. So because all the hospitals are under the Federal Ministry of Health, we're hoping to leverage on that to ensure that it sells through. So we are happy with what is happening. A few hospitals are already operationalizing it. We're hoping to take it further.
Thank you. Dr. Giselle, do you want to talk a little bit about Indonesia quickly?
Yes, thank you. So in Indonesia, like what I've said before, the patient navigation program is just starting, it's just growing. And we have like here 2 kinds of models. The one with like us, we do our own clinical navigations, and we are partnering with CIC for the non-medical aspects. While in the other hospital, they more to do the clinical navigations program. So it's kind of bit different, but yeah. But I think it's the same with what Dr. Sagaya mentioned before. If we do like a successful pilot program, so the others will follow. So like now, we have like maybe like 4 other hospital that also using like our model, so engage with the CISC and also using the ACS modules for them to start the patient navigations in the hospitals. I think that's what I can say. Thank you.
Thank you. I see we have more questions. Yeah, Jessica?
Yeah, we do have a question from Juliana of Malaysia. What the ratio of navigator to patients would be? What would be an ideal ratio?
Meaning how many patients in a week can a navigator see? I think it's something like that. And I'll just say, I think from my perspective, though I'm not an oncologist, this is, a big question even in the United States. Like, what's that magic amount of time and number of patients that can be handled? But and it's not necessarily universal. It's probably going to depend on how much time in an encounter a navigator is spending with the patient. But I don't know if anyone has a comment on that from your perspective.
I don't really know exactly, but in our system, we just introduce its new patients to our patient navigator. So they have a special room for the patient navigators touch point contact. So at least they have been introduced. So if they have any problems after, so they can come to the patient navigators anytime. So that's how there's just some patients maybe have problem and come, and the others who doesn't really need help, they don't come. So that's how we handle the almost 2,000 patients per year with only 15 patient navigators.
Yeah, that's good to know. So you have 15 full-time navigators in a week? every day?
3 per day, so
3 per
15
day.
a week.
Okay. Okay, great. Thank you. Jessica, any other questions before we wrap up?
I think just a comment from Mina, depends on the level of experience of navigator, disease type, and acuity. So I think there's a lot of variations to take into considerations.
Yeah, thank you.
What we did was, so what we did was we have a new patients clinic day, which is on Thursdays. And we give approximately maximum of 5 patients per consultant, and then a minimum of about 3 per consultant. So you're looking at anywhere between, let's say 3 times 8 is what? 40 and 20, anywhere between 24 and 40 patients per week.
For navigator?
No, not
No.
for 2 navigators.
For 2 navigators.
For 2 navigators. So, and the navigators, I have 2 of them. They come to work every day, Monday to Friday, 8 to 5.
Great. Thank you.
So it's a full-time job for them. Full-time. With
Yeah.
leave time, sick days. It's a
And
full-time job.
are you yet reaching all of the patients who need navigation with your 2 navigators?
Mm-hmm.
Okay.
They seem to be, yes, they're fine. They're able to. However, I do have a few patients who refuse to be navigated.
Another form of resistance.
A few of them, not many, but just a few. And then I've
Mhm.
asked, why don't they want to be navigated? Some say they want to use my data for something special. Others say they want to be paid. You hear the most bizarre things. They need to be paid to give their information. I think it's all, a lot of it's from, misinformation.
Yeah.
But
Thank you.
just a few of them who will be,
Yeah.
funny, but majority of them want to be navigated. Majority of them feel really good about it. It's amazing. They really, really feel good about being navigated.
And they're going to keep promoting it, I'm sure, as your
Oh, yes.
your
Oh,
navigated
yes.
patient population grows. All right. Before we wrap up, does anyone want to give a final word of advice, comment from your perspective before we wrap up today? Yes.
I think that really the Beacon initiative is fantastic. And for our region, I would suggest to use a combination of a down to top, top down strategy. And for that, I think that we would need the participation of the Pan American Health Organization for the top down part of the strategy. That is the area of WHO that are active in front at the governmental side, because it is very important to have the commitment of the ministers of health to really deal with this matter.
We got to create a lot of buy-in.
Yeah, we need to be practical and try. I understand that Beacon is a fantastic tool, but here, as in other situations, the problem is implementation.
Of course.
And we need to work on the implementation at the local level. Yes.
Absolutely. Dr. Agarwal?
Hello?
Oh.
Yeah, nothing else to add. No, I agree with all the points. I think it's going to take a multi-pronged effort, as mentioned. So we really look forward to continuing to build these collaborations cross-level, cross-team, and really excited about all the work that's been done. It was really exciting and for me motivating to hear the experiences of all the people on the ground doing this work and all the participants. So I really appreciate being invited to the panel and hearing the discussion.
Thank you. This was also creating some buy-in for our new leader. So he creates this alliance as fast as he can, and we get this work moving. All right, Dr. Giselle or Dr. Shagai, any final comments?
For me, coincidentally, the gentleman who spoke did not introduce himself, but he's actually, Dr. Uche, are you still online? Dr. Uche?
Hello, Dr. Shagai. I think he stepped out for another meeting.
Oh, okay. Coincidentally, he's the director in charge of the Cancer Health Desk, Federal Ministry of Health. So if there's anybody I needed more, it is him. So I have already started my top down.
See, there you go.
Yes, so this is I had no idea he was going to be here. So this is really good for us.
Yeah,
And
I
he'll get the
mentioned it.
recording. Great.
Yeah, I missed it somehow. So I'm really happy he's here. The buy-in has started. The NHA and UNTH
Yes,
Beacon
also other-
navigation, patient navigation
Exactly.
programs will continue to work as, pilots. And I'm sure in a few months' time, when we have this meeting again, we will definitely have something better to say. But we have started and we are still very encouraged and things are looking good.
Yeah.
Thank you. We know it's a lot of work though, but
Yeah, there's a lot of work. There
yes,
always
there's
is.
a lot of
So,
work, but we're not discouraged now.
and we're here to support you.
Thank
Dr.
you. Thank
Giselle.
you.
Yeah, I just want to say to every oncologist who attends here. So I think patient navigation is a very benefit program for our patients. So you need to start to collaborate with or partnering with the one who can help you to do the patient navigation because it's very useful, very useful. And if you we are talking about the big thing, but if I remember there are small things like it's patient stories which is really touch your heart. It happens all the
Yes.
time, so it's very useful. So why don't you start if you haven't started? And in order to this for this program to be success, your patient navigation program to be success, you have to work hand in hand, the hospital, the oncologist, and the patient navigators. Thank you. And thank you,
Absolutely.
ACS, for inviting me for this sessions.
Thank you. We are so lucky to have all of you with us and working side by side. You motivate us every day to do this work. So thank you. And I'm really appreciative that folks have stayed, that so many showed up and have stayed on the line. This session is just one of many incredible resources that we offer through the Beacon Initiative. Our Global Oncology Navigation Toolkit is designed to support our global patient navigation community of practice, which includes currently 47 cancer-focused cancer organizations or health institutions from 32 countries, and it is growing. If you're passionate about patient navigation or want to be a part of this vibrant community, we invite you to explore more by checking out our webpage, as well as we have a few short introductory videos on YouTube that really will help you understand more about what it is, what's available, and whether it's a good fit for you. Of course, if you have any questions, please reach out to us. And finally, if you are attending the World Cancer Congress in Geneva in a few weeks, let's continue these important conversations and big thinking about how best to expand the reach and quality of patient navigation in new parts of the world. We're holding a 1-hour session on Thursday, September 19th, with 4 of our institutional members in the Beacon Initiative, including Dr. Giselle's hospital and CISC from Indonesia. And we plan to launch the Global Alliance for Cancer Patient Navigation during the Congress. And we will also have an ACS booth, so please stop by and let's get connected. And finally, of course, after today, we'll be sharing a recording of the session, and really feel free to share as appropriate. And then next slide, please. Last but not least, we would love for you to fill out the survey and let us know what you thought of this session today. So thank you again to our wonderful panelists. Thank you again for your active participation, and let's keep working together to improve the lives of cancer patients everywhere. Thank you, everyone. Have a great day.
Thank you.
Bye-bye. Thank
Bye.
you.
Bye, guys.
Thank you. Bye bye.